Good evening, friends. So today we have this web meet on occupational ILD and drug-induced ILD, the best approach. Thanks to CIPLA, who are the academic sponsors for the event, and the ICS headed by Dr. Sandeep Salvi, Amitanane, and Dr. Rajadar. So today the flow of the event will be two talks by expert speakers, followed by that we'll be having a panel discussion on questions which will cater to our day-to-day needs in the management of occupational ILD and drug-induced ILD. And before we go to the first talk, I take the privilege in introducing the first speaker of the day, Dr. Sharad Joshi. Can we have the introduction of the Dr. Sharad Joshi, please? So Dr. Sharad Joshi is a director and head department of pulmonology at Max Super Specialty Hospital, Vaishali in Delhi. He has been the director and the head of pulmonology faculty and guide, and he has been a reviewer of BMG case reports, respirology case reports, and so on. And he has got a lot of publications. And apart from that, he has done his EBUS certification program from Royal Brisbane Women's Hospital, and he is also a fellow of numerous respiratory societies across the globe. Over to you, sir, for your talk on drug-induced, occupational and drug-induced ILD. Over to you, sir.
Good evening, all the faculties and dear members on the chat. And thank you for inviting me as a speaker for this interesting talk. I'd like to share my screen. Okay. I hope the screen is visible.
Yes, sir.
All right. So first and foremost thing is that out of all the ILDs, because ILD is an umbrella term, everybody knows it. More than 100 diseases are covered under this umbrella term. And why we are talking about exposure-related ILD, which is specifically to occupational exposure and drug-related exposure. Way back 20 years, almost 2 decades ago, when I was doing my MD from Udaipur Medical College, R&T Medical College, Udaipur, we used to get lot of patients of pneumoconiosis, silicosis. And after completing my MD, I have shifted to Delhi, where we rarely get minors or patients with these kind of occupational lung disease. But definitely, lungs are the most sensitive part of the body, and by all kind of occupational and environmental exposures, you will get variety of respiratory patients and complaints. So I think the most wise thing is we are talking about occupational and drug related ILD because I perceive personally that this is a preventable ILD. This is one of the subgroup of ILD where the treatment and response to the treatment will be very, very good. The only thing is that the clinician has to have a high degree of suspicion. They should have a very good, they should be very good at eliciting the history of it, and all exposure should be avoided. With this background, we know that we define ILDs and we classify ILDs in various classes, and there is idiopathic IIPs, and IPF is one of the most dreaded form which we see. Thankfully, the percentage is very, very low. Then all other idiopathic ILDs are like respiratory RBILD or cryptogenic organizing pneumonia or lymphocytic interstitial pneumonia. These are IIPs. But today we are talking about exposure-related diffuse lung diseases. And there are other diseases like sarcoidosis or LAM, and these are cystic ILDs like histiocytosis or LAM. Now the important part is that in the Journal of Internal Medicine in last December 2023, occupational ILDs was a review literature, and they have classified exposure related ILDs as hypersensitive pneumonitis, which is related to organic dust disease. And to best of my knowledge, there are more than 200 allergens which can actually cause hypersensitive pneumonitis, and we know them by various different names related to occupations to which they are associated, like berylliosis or bagasosis or bird fancier disease and lot many. Then we have granulomatous diseases, specifically like related to chronic beryllium disease. Then we have pneumoconiosis, which will be subdivided further, which is organic dust disease and most commonly seen with sandblasting and mining industries. Then we have usual interstitial pneumonia, most importantly, most frequently related to asbestosis. Then exposure to hard metal like cadmium, zinc, this causes different kind of various interstitial pattern in lungs. So hard metal lung disease is a totally separate part, and then we have drug induced ILD, which is another ILD related to exposure. Definitely, the drug related ILD is not exposure as an inhaled exposure, but it is because of hypersensitive reaction to a particular drug. So what we know is that pneumoconiosis can be because of asbestosis, silicosis or Miner's disease, or coal workers pneumoconiosis. Excuse me. Hello, Dr. Vishu.
Audible.
Any issues?
Sir, you are audible. You can continue, sir.
All right. All right. So pneumoconiosis is further classified into asbestosis, silicosis or coal workers pneumoconiosis, and hard metal lung disease, which is seen most often with the exposure of cobalt, tungsten, nickel, titanium or chromium. Now we have to identify what kind of occupational exposure or what are the industries where the exposure is most likely. So commonly associated ILDs and occupational exposures, silicosis is seen in miners, artificial stone fabrication industry, sandblasting industry and jewelry polishing industry. So if a patient has these kind of occupational exposure, we can definitely suspect for silicosis. Whenever it comes to asbestosis, most often it is with the fire or heat insulation industry. It can be miner, it can be asbestos production, insulation industry, cement production industry, or it can be boiler, marker or shipyard industry, especially in Gujarat where they have the ship dismantling industry. Definitely asbestosis is one of the risk factor. Then car mechanics or WTC, first responders or firefighters lungs secondary to asbestosis. So we will talk in next few slides about WTC lungs as well. Then we have coal workers pneumoconiosis, especially seen in coal miners and coal production industry. And we have chronic beryllium related disease, which is most often seen in aerospace and defense industries, alloy and automotive industries. Then IPF can be seen with silica related industries or vapors or gases, especially welding gases can also cause ILD related to exposure of gases and further leading to the UIP or usual interstitial pneumonitis pattern. Then definitely fumes or wood dust and agriculture dust also leads to these kind of exposure related ILDs. There are CTD ILDs also seen with certain exposure. So most commonly scleroderma is associated with silica exposure. It is more common in men. Then it has a diffuse phenotype. There are common association of digital ulceration, cardiac dysfunction and even lung cancer because of exposure to silica. Other than this, what other connective tissue disorders are seen with silica exposure are rheumatoid arthritis, SLE, dermatomyositis, polymyositis or ANCA associated vasculitis, and this association with silica has been established. This was published in Journal of Clinics North America in 2023, and the common allergens which are associated with CTD ILD like presentation, the exposure is either organic solvents, aromatic compounds, trichloroethylene, ketones, derivatives of petrochemical industries or motor vehicle production and dry cleaning industry, the chemicals which are used in dry cleaning industry. Apart from these organic solvents and aromatic compounds, the particulate material from air pollution, welding fumes, pesticides and heavy metals also increase the risk of silica related CTD ILD. So pneumoconiosis, coal workers pneumoconiosis, silicosis, asbestosis and then CTD ILD related to exposure to silica, we have seen this. The other disease which is associated with exposure to inorganic dust is sarcoidosis. The sarcoidosis is commonly associated with fumes and aerosols associated with the agriculture industry. So by digging the earth or digging the well or using various pesticide compounds in the agriculture industry, there had been an association of development of sarcoidosis. Then bakers who are exposed to high heat and fumes, and food makers, they are also at high risk of developing sarcoidosis or sarcoidosis like illness and ILD associated with these kind of occupational exposures. The inorganic dust which can cause sarcoidosis or similar illness in the lungs, and then firefighting industries, then WTC or World Trade Center first responders, and dental technicians, and people who are using solvents for machine operators or aerospace industry. Here I would like to stress upon WTC lung, which was a new terminology which came in existence after the unfortunate event of 9/11, where World Trade Towers were blasted because of the terrorist activity, and there was lot of dust particles and nano carbon ducts were seen in the lungs, which are clearly seen in these pictures. So you can see these are nano carbon ducts which are found deposited in the interstitium of the lungs of the patients who were the first responders at the WTC site, or the firefighters who responded first at the WTC disaster. And if you see the CT picture of these patients, you'll see there is fine nodularity, there is mild reticulation. This is typical of sarcoidosis, where you see a fine reticulonodular pattern, and if you see carefully, the fissure has got a nodularity, which is a typical sign of sarcoid-like reaction. And this particular picture is taken from a case report which was published for WTC lung in the first responders in US. So these kind of exposure can actually cause sarcoid or sarcoid-like illness. Scleroderma can be presentation after exposure to silica. Then RA is one thing, SLE, dermatomyositis, PMDM or ANCA vasculitis, these are also associated with the exposure to extreme blast of silica. As far as pneumoconiosis is concerned, I can remember from my MD days that it used to be called as acute silicosis, then subacute silicosis, chronic silicosis, and we used to get acute silicosis with the nodularity in the lungs, most commonly in the upper or mid zone of the lungs, and lately forming multiple PMF lesions or progressive massive fibrosis lesion in the bilateral lung lesions. This was the typical picture of any silicosis patient, and the main problem in those days was silicotuberculosis, because silicosis patients will definitely have invariable progressive crippling symptoms, and they can have secondary lung infections causing recurrent intermittent fever. But when a patient of silicosis with PMF lesion developed tuberculosis simultaneously, that used to be a very, very difficult differential, and that required lot of clinical acumen to determine whether it is just a PMF lesion with secondary infection and necrotizing pneumonia, or it is silicotuberculosis and patient actually need ATT. So this is a difficult clinical scenario. Coming back to workup of exposure related ILD, there is no it is no different from any other usual ILD workup. The recommendation we have picked up from the Journal of Occupational and Environmental Medicine, and according to this particular journal, spirometry should be done in all kind of patient who has exposure related ILD, although the recommendation is just grade B. Then chest radiograph, again the recommendation is B. The best possible recommendation is for HRCT, because it can quantify, it can subtype divide the pattern of ILD, as well as it can quantify the damage to the lung, and that is the reason HRCT scan in all ILD and exposure related ILD is strongly recommended in these guidelines. Then DLCO or sputum examination is specifically in the patients who have occupational exposure to asbestos, and sampling the bile or bronchial lavage in the patients who have got asbestos or silicosis or coal worker pneumoconiosis. because there you will get the charcoal-related crystals, or you can still get the anthracotic pigmentation and macrophages laden with anthracosis. So if you come to silicosis, the typical pattern in imaging is centrilobinal nodules, more importantly in the upper zone division, and BAL will have birefrigerant silica crystals. On histopathology, there will be fibrotic nodules containing silica crystals, and then there is interstitial fibrosis. As far as asbestosis is concerned, most commonly it is bilateral lower zone fibrosis. There are patchy or subpleural patches, and there is pleural thickening because of asbestosis. Histopathologically, there is peribronchial and subpleural fibrosis, and asbestos bodies are demonstrated in the histopathological samples. In coal workers pneumoconiosis, there will be reticulonodular opacities, specifically in upper zone. And on histopathology, the nodules contain dust-filled macrophages or anthracotic pigmented macrophages, and there is adjacent fibrosis and collagen deposition. This is what the workup or the diagnosis of exposure-related ILD would be. Definitely, all kind of ILDs, the management or the diagnostic part will remain same. For response to the treatment, for the severity of functional impairment with the ILD, 6-minute walk test and diffusion capacity is going to be the hallmark important test for the management of these patients. As far as management is concerned, pharmacological treatment for occupational ILD contains or exists is established guidelines for the treatment of any of the ILD. So obviously we do not follow the guideline for management of IPF, but if it is progressive pulmonary fibrosis secondary to occupational exposure, we treat it on the line of IPF. If you see it is more of ground glass, definitely there is an important role of anti-inflammatory drugs. If it is more of fibrosis, then definitely we have to use antifibrotic drug, whether it can be pirfenidone or it can be nintedanib. Then the most important thing which comes in the management of exposure related ILD is to grade the exposure, to find out the functional capacity of the patient and providing them with personal protective equipment so that the exposure can be brought down. Because these ILDs are not idiopathic, these are exposure related ILDs. So if we can cut short or if we can curtail on the exposure of dust, whether it is organic dust or inorganic dust, definitely it will improve the prognosis, it will slow down the progression of the disease. Therefore, exposure should be assessed and all kind of personal protective equipment should be provided. As I said earlier, 6-minute walk test is going to be the important test for monitoring the response to the treatment as well as for the progression of the disease. The process of decision making as to whether a worker has to continue in the same industry, it depends on the progression of the disease and their functional assessment. So the Journal of Occupational and Environmental Medicine, they recommend that every patient who has got any impairment in their lung function or they have got any exposure related ILD, they should get spirometry, pulmonary function testing, history taking, pulmonary function testing and 6-minute walk test. If you see any impairment, they should be provided best possible personal protective equipment. If PPE adequately can protect against the exposure, that's the best. Otherwise, patient is advised to switch from one industry to another industry so that exposure can be taken care of. And these all kind of workup should be periodically managed every 3 to 6 months. So any patient who has significant functional impairment, they should be taken off their duty, their occupational exposure, they should be changed from the occupation, as well as according to the degree of their impairment, they should be offered the compensation for whatever the damage has been done. Coming back to second part of my presentation, which is about drug-induced ILD. Just a brief introduction from Journal of Clinical Medicine. More than 400 drugs have been reported to cause ILD or interstitial pneumonitis. Most notorious are the cancer drugs. In the commonly neoplastic drugs. The most notorious drug is nitrofurantoin, which is one of the antibiotic, and the antiarrhythmic amiodarone. Almost 50% of ILD, drug-induced ILD, is because of cancer-related drugs, followed by DMRDs used in RA, rheumatoid arthritis. Then 26%, almost one-fourth of the drug-induced ILD is because of antibiotics. NSAIDs play the role up to 20%. Then psychiatric drugs also contribute to 9%, and antiarrhythmic agents up to 9%. Drug-induced ILD most commonly manifest as ground glass opacification or basal and peripheral or bilateral distribution. Many drugs will have organizing pneumonia-like pattern. Commonly seen pattern is non-specific interstitial pneumonitis or hypersensitive pneumonitis. So I will classify and come with the common drugs which cause these kind of pattern. Like pulmonary edema-like pattern can be seen with aspirin, nitrofurantoin, heroin, and methotrexate. Diffuse alveolar damage can be seen with busulfan, cyclophosphamide, bleomycin, amiodarone, methotrexate, aspirin, narcotics, or cocaine. So that's the list is exhaustive. The most important thing is that all chest specialists, pulmonary medicine specialists should know that any of the drug can be pneumotoxic, and it's very, very important to cross-check it on pneumotox.com that even if one drug has caused one side effect in lung, it is reported on this particular website. They also have a mobile app for pneumotox.com, and you can check for any lung-related toxicity of any of the drug. Bleomycin, doxorubicin, cyclophosphamide, amiodarone, nitrofurantoin, all these drugs can actually cause disease like organizing pneumonia. Then NSIB can be seen with bleomycin, busulfan, and cyclophosphamide, methotrexate, amiodarone, nitrofurantoin, hydrochlorothiazide. These are commonly used drugs. If you leave apart the cancer drugs, hydrochlorothiazide, statins, phenytoin, these are commonly prescribed drugs. Nitrofurantoin, very often written in almost all elderly patients with recurrent UTI. So we need to remember that any of the drug which you are using and a patient develops new onset breathlessness or new onset respiratory complaints, please rule out drug induced ILD or acute interstitial pneumonitis secondary to your drugs. Hypersensitive pneumonitis seen very often with methotrexate, cyclophosphamide, mesalamine, fluoxetine, amitriptyline, paclitaxel. Sarcoid-like reaction has been seen with interferon. Then constrictive bronchiolitis, it has been seen with penicillamine and sulfasalazine. So the list of pattern of ILD with versus to the drug which can cause these is extensive drug. This is one of the few cases which we published in literature. This young man came with new onset, low grade fever, cough, minimal expectoration. This patient was actually on anti-epileptic for more than 5 years. He was using phenytoin for more than 5 years. But he developed hypersensitive pneumonitis with phenytoin, which we proved after doing his transbronchial lung biopsy. Otherwise, this patient was being treated for a viral or atypical pneumonia. But after transbronchial lung biopsy, the diagnosis was established. Acute hypersensitive pneumonitis was the diagnosis secondary to phenytoin. The phenytoin was replaced with the other anti-epileptic. Patient responded very well with the short course of steroids, and his ILD completely resolved. So this is one of the few ILDs which actually can resolve. Therefore, exposure history is very, very important. Occupational exposure, drug-related exposure. Even patient might come with intake of. I remember one patient who was actually taking Ayurvedic medicine, and he presented with acute eosinophilic pneumonitis, which presents like AIP, acute interstitial pneumonitis. But when we evaluated his bowel, it had 30% eosinophil count. So we started him on high doses steroid and it completely vanished. So patient had eosinophilic pneumonia secondary to intake of heavy metals, which were actually the content of his Ayurvedic medicines. So history taking and establishing the exposure is very, very important. It can actually make a drastic difference in management of your patient of an ILD. There is another patient who was a known rheumatoid arthritis patient. She presented with 7 days fever, cough and breathlessness which worsened. This patient was being managed on oral steroid and methotrexate. We ruled out all kind of infection, including the opportunistic infections like PCP and CMV. And finally, the diagnosis was established that patient has got pneumonitis secondary to methotrexate. So her methotrexate was stopped, steroids were escalated, and all these patterns which you see, that there is air trapping, there is mosaic attenuation, there are ground glass hazing, everything resolved, and patient came back to her normal baseline respiratory parameters. So once in a while you will come across these kind of exposure related ILD, whether it is drug related or whether it is dust or occupational related. Thank you. I open to the panel for further discussion specifically on drug related ILDs.
Yeah, thank you, Dr. Sharad, for this wonderful talk. So, moving on further, can we have the introduction slide of the next speaker? So, to deliver the next talk, we have Dr. Khushboo. She doesn't need much of introduction, especially with the pulmonary forum. Like, she is one of the radiologists who's dedicated in the field of pulmonary medicine. And she is currently working in, she's a founder and a consultant radiologist at the Eisen Imaging and Intervention in Noida, and consultant radiologist in Picture This by Dr. Jankaria. She has got numerous credentials and she is a member of various organizations, and she has delivered various guest lectures at national and international conference. So today we have here with us Dr. Khushboo to deliver a talk on imaging in occupational ILD and drug-induced ILD. Over to you, Dr. Khushboo, for your presentation.
Thank you so much, Dr. Viswesvaran, for that introduction. I'm extremely sorry for this mess up and these last minute delays. My computer just crashed out and I don't know what happened. So I am trying to share my screen instead. So are you able to visualize my screen well?
Yes, ma'am, we can see it.
Yeah.
Can you just put it on the full screen mode? Yeah.
I'll just do that. Okay. So again, I would like to thank ICS and the entire team, Dr. Amita Nene, Dr. Rajadhar sir, and Dr. Sandeep Salvi, Dr. Viswesvaran, for having me here. It's indeed a great pleasure and honor. What we'll be talking about is occupation and drug-induced ILD. The work has been made much simple for by having Dr. Sharad Joshi sir speak on the same topic, and he's given a complete outline of what we are talking about, and I will be just taking ahead of what he stressed all the while, that HRCT chest is something that we need to be discussing and doing in every patient who is suspected to have these diseases. What will HRCT show is our question, and what we need to pick up on the HRCT when we need to very confidently say that yes, it is an occupation related ILD or a drug related ILD is what we will be discussing on. So obviously, what is an occupation related interstitial lung disease? It is an interstitial lung disease where a direct causative relationship between the occupational exposure and ILD has been established. This can be established basis a very strong occupational history and without any other comorbid other factors which could explain the ILD the patient has. Amongst the various kind of occupational exposures that lead to the interstitial lung disease, coal mine dust lung disease is one of the commonest. Varying patterns of lung involvement can happen with coal mine exposure. So along with coal mine exposure, there is silica exposure. So silicosis is a common complication of coal mine related exposure, apart from silicosis being associated with other mining related diseases as well. Then we have coal mine pneumoconiosis, where it is due to exposure to the coal dust. We have mixed dust, which means a mixture of silica as well as coal exposure has related to some changes in the lung. Then the dust, and not specifically the coal and silica, but the dust which is related with mining can lead to diffuse fibrosis. And apart from that, COPD is also a common complication, which ways we will not be dealing with currently. We start with silicosis, one of the most talked about interstitial lung disease. And again, I will also stress on the same fact that while I was working in Jaipur, I used to see these cases almost on a daily basis. But since I've been in Delhi for all this while, we hardly see these cases. And it is equally difficult even to, find out and pull out these cases, which becomes. So this itself shows the occupation relation. So in these areas, these mines are not there, and hence these exposures are not there. So silicosis has different spectrums on CT scan. It can be a simple silicosis, it can be a complicated silicosis, or it can be an acute silicosis or a silicoproteinosis. How do these look on a CT scan and how we can differentiate? So number one, obviously the patient has an obvious history, an obvious exposure to silica history, an obvious occupational history. In these patients, if you see an interstitial lung involvement in the form of multiple scattered randomly distributed nodules with an upper zone predominance with mediastinal lymphadenopathy and may or may not be some plaques or pleural thickening, then you should strongly suspect silicosis. The only differential to such randomly distributed nodules in the lungs is tuberculosis, that is miliary tuberculosis or some disseminated metastasis. Obviously, these two have their typical history. Miliary tuberculosis presents very differently. And so the list of differentials is very limited. If we know this pattern, there are only 2 to 3 thoughts that should come to our mind, and once we have only these limited thoughts to be able to differentiate them, basis the history becomes much easy. So this is how a simple silicosis looks like: multiple tiny discrete randomly distributed nodules in bilateral lungs. Complicated silicosis. What is complicated silicosis? When the exposure has continued for long term without any active measure being taken to see what's happening in the lung or to treat what is happening in the lung. This is how these diseased, complicated silicosis lungs look like. So it is also known as progressive massive fibrosis. You see large areas of consolidation or fibrosis in both lung parenchyma and with a background of multiple nodules. So this is a very typical picture. So you see these large patches of consolidations in both lungs, more towards the periphery rather than towards the hila. So towards the hila is what happens more with sarcoidosis. However, when it is more towards the periphery, it happens with progressive massive fibrosis associated with silicosis or colorectal pneumoconiosis. You see a background lung with multiple scattered nodules. So these nodules are all discrete and randomly distributed nodules, as I said, occur with silicosis. Apart from that, another very characteristic feature of silicosis are these calcified mediastinal lymph nodes with eggshell calcification. So you may see that there are a lot of similarities with how sarcoidosis presents and how silicosis presents, but then there are very specific differences. So for example, the distribution of the nodules, which is more peribronchovascular and perifissural in sarcoidosis as compared to these randomly distributed nodules. Then the distribution of the fibrosis, which is more towards the hila in sarcoidosis, whereas which is more towards the periphery in these silicosis patients. And these calcified mediastinal lymph nodes with a very typical eggshell calcification, which is not the case with sarcoidosis. So this is silicosis with progressive massive fibrosis. Now, as we talked about silicosis with tuberculosis. So in this patient with a known exposure to silica, you see these randomly distributed scattered nodules in the background lung and large cavitatory consolidation in the right lung. So this is a complicated patient where silicosis, on top of silicosis, tuberculosis is developed. It is also known as silicotuberculosis. Then acute silicosis or silicoproteinosis. Now this is a rather rare condition, occurs only when there is a very huge exposure to silica in a short interval of time. So very concentrated exposure to silica. It presents more like an ARDS, and then you have these large patches of consolidations or large ground glass attenuation, extensive septal thickening in the lung parenchyma. The lung picture is also more or less like a diffuse lung disease. So when you see such a presentation, then in obviously a patient who has a very typical history of highly concentrated silica exposure, then you should be thinking of acute silicosis or silicoproteinosis. A common radiological differential is pulmonary alveolar proteinosis, but the same picture can be seen with acute silicosis if given the history as we discussed. So this we've already discussed how to differentiate silicosis from sarcoidosis. So they have a very similar pattern. If you see nodular disease with bronchosvascular consolidations, then you have lymphadenopathy with calcification. But all of these features have a very typical distribution, which is different between silicosis and sarcoidosis. And if we are mindful of these patterns, it will be very easy to differentiate one from the other. Then coal workers pneumoconiosis. So this is something which is very similar to silicosis. On imaging, we cannot differentiate a coal worker's pneumoconiosis versus a silicosis. So whether the silica dust caused the lung insult or the coal mine dust caused the lung insult is difficult to differentiate. This can be done only on histopathology, the imaging pattern. So this is again a progressive massive fibrosis, background nodules, discrete, randomly distributed, a patch of consolidation, and these eggshell calcifications. So the pattern is more or less similar. Then in coal mine workers, you also have dust-related fibrosis, which shows a pattern similar to a UIP pattern. You have interstitial fibrosis, honeycombing, architectural distortion, and over time, these patterns keep progressing if the exposure is not removed. So that was coal workers pneumoconiosis, the pattern of lung insult that happens in a patient who is exposed to coal mine. Then we have another very common in occupation-related lung disease, which is asbestosis-related thoracic lung disease. This leads to a very typical UIP pattern. We have ill-defined intralobular, interstitial septal thickening, honeycombing, traction bronchiectasis, architectural distortion, basal predominance of the disease. It very much mimics a UIP. If we don't have a history of asbestos exposure, we can easily mistake it for a UIP pattern. One telltale sign is to look at the pleura. If you see calcified pleural plaques, then aggressively go back and retrospectively try to find out a history of exposure to asbestos. So this is a pattern which we see with asbestos-related interstitial lung disease. As I said, very typical pattern as we see with a UIP, IPF pattern. So intralobular interstitial septal thickening, traction bronchiectasis, basal predilection, architectural distortion. But what we also see are these calcified pleural plaques. So the moment you see these calcified pleural plaques, these are not seen with UIP, IPF. So the moment you see them, please thoroughly try to find out if there is an asbestos exposure, because they lead to these pleural reactions. And also, as we know, mesothelioma is a common malignancy associated with asbestos exposure. Another common, not so common although, interstitial lung involvement that we see with occupation-related interstitial lung disease, or rather this is more often seen in these belts like Delhi, etc., is the giant cell interstitial pneumonia pattern. So it is caused due to exposure to hard metal compound in paint industries, etc. This gives to a very typical pattern of ground glass attenuation in the lungs with some irregular interstitial linear opacities and with tiny interspersed cystic areas. So when you see such diffuse ground glass, tiny interspersed cystic areas throughout the lung, so it's a combination of cystic lung disease and interstitial lung disease. It's a cystic lung disease with background diseased lung parenchyma. When you see such a pattern, there are very limited differentials. So when I look at such a pattern, I'll be thinking of lymphocytic interstitial pneumonia. If you know the patient is not a known case of CTD, ILD, the patient is not immunocompromised, that diagnosis goes out of our mind. There's maybe hypersensitivity pneumonitis, a good and a strong history of any such antigen exposure, then maybe we rule. Same time, we can say that maybe the extent of cysts is disproportionate to what we see with hypersensitivity pneumonitis. And the extent of GGO is also more. So these are a few things that often raise a question within your mind that maybe if it's not hypersensitivity, and then in these cases, if you find this typical history of an occupation which has an exposure to hard metal compound, think of giant cell interstitial pneumonia. maybe a patient with a background emphysema, so a smoker. That is another history we need to figure out. And if not a smoker, then we know. So this was an giant cell interstitial pneumonia and a non-smoker working in a paint factory. Then hypersensitivity pneumonitis pattern. So again, this is a very common that we see with both occupation-related interstitial can cause a hypersensitivity reaction in the lung and lead to this pattern. So that was about the occupation interstitial lung disease. Now we talk about the drug-induced interstitial lung disease. So drug-induced interstitial lung disease, either drug toxic hypersensitivity reaction of the lung parenchyma to certain drugs. This has already been elaborated in detail by Dr. Sharad Joshi, that these are the list of the most common drugs which cause interstitial lung disease. So a very thorough history of if the any of these drugs, so if the patient has interstitial lung disease, we need to take a thorough history of if the patient is taking either of these drugs. The most common patterns of pulmonary drug toxicity that we see with drug-induced ILDs, you either see an end-turn UIP pattern, HP pattern, organizing pneumonia pattern, and rarely if there is an acute drug toxicity, ARDS and diffuse alveolar damage. There are a few risk factors which predispose certain patients more to a DILD versus another. So if multiple drugs are being taken, patient is already on chemotherapy, has some other inflammatory systemic disease, old age, of radiation exposure, and due to other drug interactions, renal dysfunction, liver dysfunction, which decreases the excretion of the drugs. So if there are any such comorbidities, these patients are more prone to have a drug-induced interstitial lung disease. With drug-induced interstitial lung disease, some things are very simple. So a patient is taking a drug, gets some respiratory discomfort, presents to us, CT scan is done, and you see these infiltrates in the lung parenchyma. You figure out that there is a certain drug which can cause such infiltration. You remove the drug and the opacity is resolved. It is documented and proven that so this is the simplest way to prove it is. Often the question is that if the drug is withdraw the drug. In those cases, it becomes a bit of a tricky situation to figure out and versus to something else. So then we need to know what are the specific patterns which can make us more wiser. So now let's talk about the few common drugs which cause the ILD. Methotrexate is one of the commonest ones. The mechanism of action and the mechanism of injury to the lung is due to hypersensitivity reaction. But the most pattern of lung involvement due to that hypersensitivity reaction is NSIP pattern. Other patterns like OP, AIP, pulmonary fibrosis, etc. can also occur. So there needs to be an exact temporal relation intake and the interstitial lung involvement, and if at all we can document that the removal of the drug leads to improvement in the lung infiltrates, then it's even more proven. So it's a very typical pattern, a patient of psoriasis with some very complaints presented with this lung pattern. So you see ILD lung pattern, a relative basal comorbidity and apart from psoriasis. And when this drug was withdrawn, the extent of ground glass attenuation in the lungs decreased significantly. The withdrawal of the drug and the infiltrates decreased significantly. Then in this case, you also see the patchy peribronchovascular ground glass attenuation. So this is while the patient is still on methotrexate, opacities will decrease. Incidence of interstitial lung disease is bleomycin. Up to 10% of the patient develop interstitial lung disease. The more followed by NSIP pattern. does not. So we see this is a patient with CA breast. Pre-treatment, the lungs were clear. 3 months post-treatment, you start seeing these patchy peribronchovascular consolidations, which become more intense 6 months post-treatment on bleomycin. So very characteristic temporal relationship with bleomycin treatment. One of the last drugs which I will be discussing is amiodarone, very commonly associated with pulmonary toxicity. Early cases leads to GGO. Cough is commonly associated, and over time, when you see the lung involvement, you see GGO, pleural thickening, reticulation, traction bronchiectasis, a UIP pattern of fibrosis. Often you see consolidations which show a very high attenuation pattern because of the iodine content of the amiodarone. So the interstitial involvement is very much similar to the way you see with UIP, IPF. You see ill-defined intralobular interstitial fibrosis. The extent of ground glass in almost all the drug-related interstitial lung disease is always on the higher side, because these diseases more often have a significant ongoing acute inflammatory component, because the moment you withdraw the drug, the ground glass goes away. So while the patient is on drug, you will always see these ground glass attenuation. In this case, you also see this typical high attenuation within the lung parenchyma due to amiodarone deposition. And there is also pleural effusion. So maybe that is due to the cardiac disease which the patient already has. Nitrofurantoin mostly results in some pulmonary fibrosis, which is more often irreversible. There's a very beautiful diagram which shows certain common drugs and their patterns. So maybe you can take a snapshot of it. I took it from this Diagnostics 2020, very interesting. So you know that aspirin, mitomycin causes more of pulmonary edema. Effusion is through sulfonamides and methotrexate. Organizing pneumonia is more common with nitrofurantoin, sulfasalazines, and methotrexate. So this just sums up what kind of opacities are to be expected if the patient is on one over the other drug. A few take-home points are that a thorough history of exposure is a must, both occupation and drug-related. Whenever you see scattered, randomly distributed nodules in a patient with some occupational history, or when you try to find out an occupational history, if there is nothing to suggest biliary tuberculosis, think of silicosis. Tuberculosis is a huge mimicker for tuberculosis, but there are certain features which can help us differentiate. We've already discussed it. We should know about hypersensitivity pneumonitis, which is a pattern of lung involvement. Site or the ground glass, relatively less talked about interstitial lung disease, should be thought about. And you should look at the resolution of findings with when you should be thinking of a drug-induced ILD. So thank you.
Yeah, thank you, Dr. Khushboo, for the beautiful presentation. It sums up almost all the imaging aspects of occupational and drug-induced ILD. But I have like one or two questions for you. So one of the most common pattern of presentation we see in a drug-induced is an NSIP. That's what we all read it in the books. So how do you differentiate whether it is a drug which has caused that NSIP or it is an idiopathic NSIP? Are there any specific pointers that we have to look into the CT scan which can suggest us whether it is a drug-induced ILD or it's an idiopathic NSIP?
So that's quite a tricky question. But one thing that we can take as a dictum is that idiopathic NSIP is rather rare. Or there is nothing like an idiopathic NSIP. Whenever you have an NSIP pattern, we should always very aggressively look for some underlying cause. The underlying cause could be a CTD-ILD. If you are very sure the patient does not have a CTD-ILD, look for any other inciting agent. So drugs can be one. If you have an obvious drug which is known to cause an interstitial lung involvement, the patient has an NSIP pattern, the patient does not have CTD-ILD, attribute it to it. If the patient does not have any drug exposure, then anyways it is out of question.
But would you think like having some sort of a plural effusion along with an NSCP like presentation would point more towards a drug-induced reaction phenomenon?
I missed your I missed your question, Dr.
Can you hear me?
Vishwesh, your voice cracked.
Can you hear me? Can you hear me now?
Yes, I can.
So do
Yes,
you
yes.
think like certain other
I can.
like a plural effusion associated along with an ELD NSAP like pattern would point more towards a drug induced or something like that? Because generally most of these drug induced ILDs tend to have some element of a plural effusion also in certain cases.
I have been able to hear a question only partly, Dr. Vishwesh. If I am correct, what I heard is that you're asking if pleural effusion is associated with drug-induced ILDs.
Yeah.
Okay. Yes, that is something. So when you see an ILD and you see effusion, there are two thoughts that come to your mind. Number one, CTD related ILD, other is drug-induced ILD. So these are the only two thoughts that come into your mind. Apart from that, a secondary complication. So maybe if there is some cardiac issue which has led to the pulmonary edema. Otherwise, ILD and effusions do not come together.
Yeah. So another question which you briefly touched upon as well, like how does amiodarone induced ILD tend to differ from other sort of ILD? Because we hear that it is little more radio dense than the other sorts of ILD. So what is your experience? Are you able to pick up that radio density and clearly point even without a preceding history of a amiodarone induced ILD? Right.
Your voice is cracking, Dr. Vish.
Can you hear me? Can you hear me now?
No,
Am I audible?
No.
It's okay. Like I think there is some.
Yes, you are. Yeah.
Yeah. Can you hear me now?
Dr. Vishwesh, you are clearly audible. I think there is some issue in network.
Yeah. So I think in the interest of the time, we'll skip this anyway. We'll have it as a part of a panel discussion. So now we'll move on to the panel discussion. So can we have the introduction slides of the panelists? So we heard two very good talks both upon the clinical aspects as well as the radiological aspects of occupational and drug-induced ILD. So now we move to the interesting part of the day, which is the panel discussion. And to have this, I'll be moderating the session, and we have a set of esteemed panelists. Dr. Ashok Kumar Singh, he is a accredited teacher in the DNB super specialty, and he is currently working in Regency Hospital in Kanpur, and he's a director and academic course coordinator in the Department of Pulmonary and Critical Care Medicine, and he has got numerous credentials to his name, and he is also the secretary of ICS in the UP state. We move on to the next panelist. We have Dr. Padma Sundaram. He's an ex-senior consultant pulmonologist at Manipal Hospitals in Hall Road, and currently she is working in the Fortis Hospital, Cunningham Road and Richmond Road, and she has got numerous awards and has published over 50 papers in the national and the international journals, and she has got a special interest in airway disease, ILD, and sleep medicine. So to join us, our next panelist is a young and dynamic Dr. Shubhra Jain, and she is an associate professor in the Institute of the Respiratory Diseases, SMS, Medical College, Jaipur. I don't think anybody would be more appropriate than her to speak on an occupational lung disease where she comes from, because in Rajasthan, we all know that they face a lot of occupational lung disease, especially silicosis. And her areas of interest include allergy interventions and critical care. She has got numerous publications in various national journals, and she has also got her fellowship in Indian Diploma in Critical Care. With this, we move on to the last panelist, a very good friend of mine and a very dynamic pulmonologist in the city of Jaipur in Rajasthan, and he is been the state head for the Chess Council of India in Rajasthan chapter, and has been a core committee member in various national conferences, and he has got to his credit of participating in more than 100 academic events, conferences, and he's a part of reputed international and national societies in the field of pulmonary critical care and allied sciences. So we have a set of very esteemed panelists who have rich experience in managing all this occupational lung disease as well as the drug-induced lung disease. So I'll be moderating this session, and I think Dr. Padma Sundaram ma'am might be introducing me to this set of audience here.
So thank you, Dr. Viswesvaran. It was great having you here, moderating this session, as well as introducing the speakers, as well as a great talk by both the speakers, Dr. Joshi and Dr. Khushboo. So Dr. Viswesvaran needs no introduction. He's done his DM. He's a gold medalist. He's associated with Yashoda Hospitals in Hyderabad. He's doing great work in interventional pulmonology, both in the real world as well as in the virtual world. He has got more than 30 publications to his credit. He's a reviewer in national and international journals, as well as he's an invited speaker for both in national and international conferences. So, Dr. Viswesvaran, please go ahead and start the panel discussion.
So we'll start the panel discussion, and my first question is to Dr. A.K. Singh, sir. So you must be having a very rich clinical experience, and in your clinical practice, how commonly do you encounter an occupational ILD? And have you observed any sort of an increase in the occupational ILD in the recent times? And if so, what would be your what reasons would you like to attribute to the increase in the incidence of these occupational ILD, sir?
So, very good evening, everyone. We see large number of patients of occupational lung disease. It's very difficult to pinpoint the exact number, but definitely it is underestimated and underdiagnosed conditions. We see the two types of patients, especially pneumoconiosis and hypersensitivity pneumonia. Among the pneumoconiosis, we see the silicosis and hypersensitivity pneumonia, because it's a wide spectrum of the presentation, is really difficult to diagnose. But the large number of patients of hypersensitivity pneumonia or interstitial pneumonias is because of the occupational exposures. Because in UP, there is no sand or this cement factories. Most of the patients are coming for the MP or Rajasthan. But significant number of patients of pneumoconiosis, especially silicosis, silicotuberculosis, we see in day-to-day practice.
Yeah,
the number has increased because of the more awareness, and second is because of the diagnostic facility we have, and we are more experienced to see the X-rays in the patients. We diagnose even the patient in the OPD as well.
Yeah, very true, sir. Even we see a lot of cases of occupational lung disease off late, primarily because we get more access to the CT scan, which was not the case a few years back. So now, right now, we see a lot of ILD, and many times when we probe, possibly these patients could have had an occupational exposure, and definitely there is an increase in the incidence of occupational ILDs. So moving on to the next question to Dr. Padma. So when a patient comes to us with a case of a suspected occupational induced interstitial lung disease, are there any specific questions would you like to ask your patient regarding the occupational exposure, or do you go by a checklist method, or is it like you have a focus questions to their symptoms to find out an occupational history?
So in all patients of interstitial lung disease, we need to have a detailed occupational history. It becomes very mandatory because we may miss out their occupations. So you should also ask it in a chronological order. A lot of times, patients may have exposed to some dust exposure early in their job, and they may have forgotten about it. So a chronological history is very important. A temporal association with their symptoms also becomes very important. And is there any of their co-workers also suffering from the same disease? So these are three important clues which could tell us that, is this an occupational related interstitial lung disease? Obviously, as Dr. Joshi has mentioned, all the list of occupations. So if you are featuring something like a silicosis, you would ask all those occupations related to silica exposure. Inorganic dust like, asbestos or school workers, pneumoconiosis, or often organic dust if you're suspecting hypersensitivity pneumonitis. So these are important questions that we need to take our time. Abroad, they have questionnaires which are like proformas given to the patients. But considering the shortage of time in our OPDs, we tend to skip that. But we need to have a detailed occupational history from each and every patient, including if they're working in any aerospace industry, sandblasting, etc., mining. So these are important questions to be inquired.
Yeah, this is very, very practical points which you have put up, ma'am. Mainly the chronological aspects. Many times we tend to forget it. We tend to ask them about their past. And another thing is, as Dr. Padma has already pointed out, like if you cannot find a reason for an ILD, and if you have a very strong suspicion of a occupational ILD, then I think it's worthwhile to consider a checklist method and a questionnaire method. Sometimes we may think that the occupational exposure might be non-significant, but later on that might be the true reason for a interstitial lung disease. So with this, we move on to Dr. Shubhra Jain. What are the spectrum of the occupational lung diseases do you see in your clinical practice? Is it always an ILD, or you find a lot of these bronchiolitis associated with an ILD? Or what is the spectrum that you see? I know you come from Rajasthan, which is the hub of most of these silicosis and other things. So we would like to hear from your experience on the same.
So like all the spectrum discussed, we see mostly cases of silicosis, and it varies from acute silicosis to chronic silicosis. And commonly we see chronic silicosis. So we see nodular picture more, progressive massive fibrosis cases, and sometimes these cases mimic lung cancer also. That PMF lesion sometimes mimic lung cancer. And these patients of silicosis usually presents with pneumothorax or with symptoms of suggestive of tuberculosis. Even semi-invasive aspergillosis can be seen in these patients, and sometimes with features suggestive of autoimmune diseases like systemic sclerosis, rheumatoid arthritis. So we see these type of pictures along with nodules in these patients.
Yeah. And Dr. Ankit, so when such patients come to you like with these occupational lung disease, do you have any particular sort of a notification system, and how does it really work in Rajasthan? And once, let's say that an employee gets a occupational lung disease primarily because of working in the sand industry or in the sculpture or something, so does the government compensate them for the occupational hazard, or how it works in real world?
Yes, definitely. There is in certain Western countries, there is a robust system for these occupational diseases, particularly UK and certain parts of Australia. There has been a very intensive surveillance going on these work-related occupational diseases like SWORD. So if we see in the Indian context, there is a Factory Act, which was in 1948, and there was a third schedule in it. So they have mentioned around 29 diseases as a notifiable diseases. If we see the occupational lung diseases in that, silicosis, pneumoconiosis, asbestosis, byssinosis, and mesothelioma, they are particularly the notifiable diseases as per the Ministry of Labour and Employment, Government of India. So now various employees, state insurance corporations, that is ESI, has been established, and they have established a branch of occupational disease centers, that is ODCs. So there are around 7 in number in all the countries. So they have been given the responsibilities that how they will diagnose, they will manage, they will basically have all the diagnostic facilities, preventive part, and to decide for the compensation related to these patients. In Rajasthan per se, we say that, as Dr. Shubhra has rightly said, that silicosis is very rampant. So from year 2013 to 2015, many things has been done for the diagnosing, preventing, and possibly compensation of those patients with silicosis. So obviously there is a medical board which consists of various specialists in the field, in and out, and possibly assessing the condition of the patient, they decide for a suitable compensation.
Yeah, true. And with so many migration happening, like people coming across the countries from different parts, I think many of us who are listening here, though we are not from silicosis prone region, we may see a lot of patients who migrate from there to our city. So I think it is worthwhile to understand that whenever we establish a case of a silicosis induced lung disease, probably it must be notified, and in case if they are eligible for compensation, I think it will help our patients in a big way. So
just one more thing, Dr. Vishwas.
Yeah,
actually, the government, Rajasthan government, is giving 3 lakh compensation to patients of silicosis, and once they die due to silicosis, another 2 lakhs are given to these patients. So it depends on region to region. Like we have miners, we have idol makers, brick making industries, sand quarrying. That's why we find silicosis. And Dr. Sharad has told that in Delhi they hardly see silicosis. So this is the variation.
But I think having said that, I have had an experience of being in Delhi for 6 years, and Delhi has a lot of these migrant population. So basically, though they are not actually get exposed in Delhi, they move to Delhi, they settle down in Delhi, and after very years of being in Delhi, they come up with the manifestations of silicosis. That's why, as Dr. Padma has said, you need to take the chronological history very seriously, because many a times you will be biased thinking that silicosis is not common in Delhi, but they might be the settlers from the silicosis prone regions, which we miss it until and unless we really look for that history. So, Dr. Sharad, it was an excellent talk. And one of the things that we see when it comes to silicosis, we are always worried whether it is just a silicosis or the PMF is also a part of a tuberculosis. So that confusion always exists whenever we see the CT scan, because you can get nodules, you can get masses, you can get lymph node, lymphadenopathy, everything, both as a part of silicosis as well as a part of silicotuberculosis. So how common do you see tuberculosis in a silicosis patient, and what precautions would you advise to your patients, especially if they are post-silicosis patients, to refrain themselves from getting infected with TB?
Thank you, Dr. Viswesvaran, for the question. And now I feel fortunate that I have completed my post-graduation from Rajasthan. And Udaipur is one of the reason where you get most patients of pneumoconiosis, silicosis, silicotuberculosis, and PMF lesions. And as rightly said by Dr. Shubhra, that even PMF lesions might be confused with malignancy as well very often. So in chronic silicosis, patient is going to have long-standing respiratory complaints, cough, breathlessness, chest pain. All these symptoms are going to persist. But when it comes to and because of tachypnea, these patients might have pulmonary cachexia as well coexisting with it. So it becomes very difficult to differentiate it from active tuberculosis.
Yeah, that's very true. Yeah.
Most importantly, if you go by symptomatology, fever is one of the symptom which is not seen in silicosis per se. So a low grade, long standing fever of more than 2 weeks, definitely you should think of a tuberculosis over and above the background of the silicosis.
Yeah.
Secondly, if the patient has new onset or there is radiological change with cavitation, because even a PMF lesion can have necrotizing features, but a new onset cavitation is one of the features which will suggest that it is turning into silicotuberculosis, or there might be a tuberculosis on the background of silicosis. Thirdly, if you see that the patient has worsening in the symptom and he is bringing out sputum, it is always wise for every follow-up, patient should undergo a sputum examination with AFB stain.
Yeah.
Because silicosis is a chronic crippling disease, symptomatology will be a confusing thing. But long-standing fever, low grade, then cavitation and sputum examination will definitely establish the diagnosis of silicotuberculosis.
Yeah, this is a very true, sir.
If the panel permits, I will talk about, because we have been always discussing about the occupational exposure related ILD. But I had one patient from ordnance factory in Meerut, and this patient was exposed to certain chemicals used for ammunitions, manufacturing ammunitions, and this patient got admitted 3 times in 4 months duration with pneumonia. So there was no interstitial shadows, but there was always pneumonia, and his cultures was positive. First time it was Pseudomonas, second time it was Klebsiella in 2nd month, and after 3 months he presented with MRSA. So that was very surprising, because patient had no HIV, no diabetes, no immunocompromised state, and patient was having recurrent life-threatening pneumonias. So we went ahead and we performed the bronchoscopy. We showed that there were multiple intrabronchial masses, and we biopsied it, and it turned out that these are just pseudo tumors of inflammatory etiology. So this patient had occupational exposure to certain chemicals during the manufacturing on ammunition, and we removed his exposure. We gave him inhaled steroids, and all pneumonias and these intrabronchial masses were totally vanished. Yeah. So it is, as Dr. Padma has labeled, that chronology and exposure history. This is actually the key to your treatment of patient and identifying the patient.
Yeah, very true. So for the audience here, whenever you have a patient of silicosis, if they are having a fever which lasts for more than 2 weeks, or patient is having an unusual loss of weight or loss of appetite, or you see a sort of hemopsis in them, or if you see a radiological evolution of a mass-like lesion breaking down into cavity, or you see a lot of centrilobular nodules, then probably you need to have a very high suspicion of silicotuberculosis. But the unfortunate problem is many a times you may get a negative sputum report because most of this AFB can be can be contained by that inflammatory process, so they actually do not expect it. So it is worthwhile to even go for a bronchoscopy or even a endobronchial ultrasound of the mediastinal nodes to get a diagnosis of tuberculosis. Apart from that, one interesting point with Dr. Sharad raised, yes, it is advisable to get at least a periodic sputum evaluation done, because sometimes you may pick up tuberculosis much early in these patients, and that really changes the management of these patients because they are going to come to you with already a compromised lung. So with this, we move on to Dr. A.K. Singh. What workplace precautions would you like to advise to your patients to avoid an occupational lung disease? You will see a lot of patients whose primary source of income actually depends upon that occupation. So just saying that you move away from the occupation, though sounds very idealistic, might not be a solution for most of these patients where they are the primary breadwinners and they come from a economically deprived situation. So in case if they want to continue in the workplace because of these reasons, what precautions would you really like to advise to your patients?
So application of preventive measures are very, very important part of this management of occupational disease, because most of the disease are irreversible and they're the progressive disease if they remain having exposure to this culprit of molecules. So most important thing is to prevent the exposure of these harmful molecules. And that can be done by the two way. One is you have to educate the whole staff. They should aware of the disease, that this the type of the disease can be developed, so that they can explain, they can inform whenever they have the symptoms, number one. And there must be some provision by which we can decrease the exposure of these harmful molecules, like use of mask, respirator, they should use PPE, there should be good ventilation. Smoking is one part which aggravate the all occupational disease. So these are the few measures, although there are various guidelines for all occupational diseases, but it's difficult to practice. But these are the basic things which could be done.
Yeah, excellent points, Dr. A.K. Singh. And it is sometimes in a busy clinical practice, we are more concerned about establishing the diagnosis and treating the problem rather than looking into what can be done to prevent the progression. So at least after COVID, I know that most of us are well versed with advising the respirators and N95 mask, which I think is easily accessible even to the general population, unlike the pre-COVID era. So that is something which can really play an important role. And as Dr. A.K. Singh said, smoking cessation. Sometimes we take it very lightly. We are like more concerned in administering bronchodilators to these patients, and even without going into the smoking cessation programs, rehabilitations, and even nutrition for that matter, because unfortunately you see most of these patients who come from these strata are very nutritionally depleted. So I think a certain amount of a holistic approach in the management is what that will really change the outcome of these patients. So I think we have touched a lot about the occupational lung disease. Now I'll move to Dr. Padma a little bit on the drug-induced ILDs. So what are the drugs which are associated with the drug-induced ILD, and how commonly you see these drug-induced ILDs in your clinical practice, and what is the profile of the drugs actually you see in your clinical practice causing an interstitial lung disease?
So most of the times that we see drug-induced lung diseases comes from our referrals from the oncologist and for the rheumatologist. Now, from the oncology, we all know the conventional chemotherapy is always known to cause drug-induced lung disease, like your bleomycin, your busulfan, cyclophosphamide. But we also need to know that the newer agents which have been discovered, like the TKIs, can cause drug-induced lung disease, as well as the fact that the newer agents, like we have the immune checkpoint inhibitors, nivolumab and pembrolizumab, they've also been reported to cause drug-induced lung disease. So almost most of the chemotherapy drugs can cause it. So we get referrals from the oncology team. The second group of drugs that we commonly see is the DMLDs, that is from the rheumatologist. The conventional ones were usually the methotrexate and the sulfasalazine, but also the newer biological agents that have been used, like infliximab, rituximab, etc., can also cause that. So the third group of drugs is from the cardiology practice, the amiodarone, when it is used for more than 400 milligrams for a long period of time. We always need to have in mind that amiodarone can cause this injury. One thing which you commonly miss out is the radiation-induced lung fibrosis, a part of the chemotherapy and radiotherapy regimens. We commonly see even treatment of breast cancer, radiation-induced lung fibrosis. So these are the common drugs. Obviously, nitrofurantoin, yes, it has been reported, especially in ladies taking recurrent nitrofurantoin dosages for their urinary tract infection. So these are the common drugs that we see in drug-induced lung injury.
Yeah, very true,
And
Doctor.
obviously, the last would be oxygen if it is used in the intensive care unit for a long time with an ARDS like picture. So
Yeah,
these are the
that's a very,
common.
very valid point which you have put. Sometimes we don't even consider oxygen as a drug. We take it for granted that any oxygen is fine for the patient. But yes, as you rightly said, excess of oxygen can in turn cause fibrosis. But one another thing, especially one interesting thing which we saw is sometimes a patient comes to us with a rheumatoid arthritis background. He'll be taking liflunomide and he will develop some lymph nodes. You sample these lymph nodes, you get a sarcoid like reaction. Sometimes we think it's sarcoidosis, actually it is a drug induced sarcoid secondary to liflunomide. That is something interestingly we have observed in few cases. And as you rightly said, with so many biologics coming around, I think every doctor here, irrespective of the specialty they deal with, should have some idea about the immune mediated pneumonitis which are seen with most of these biologics and the newer agents. So now we'll move on to Dr. Shubhra Jain. So now we heard that these drugs can cause an interstitial lung disease, but are there any definitive criteria, or it is just like a temporal, I took the drug, I have an ILD, so it is a drug induced ILD, or is there a definitive criteria to say, criteria to meet to be called it as a drug induced ILD?
So recently there is a paper from Fleshner Society which has proposed 3 diagnostic criteria. One is, first is appearance of bilateral, non-segmental, new infiltrate in thin section CT. Second is should be some temporal association with administration of that systemic drug. Third is that you have to exclude all other causes of ILD as well as differential diagnosis of ILD like infections, heart failure, and lymphangitic carcinomatosis, and many others. However, there is a important thing that in spite of these criteria, we can sometimes also see peripheral eosinophilia in few subset of patient, and the history of timing of onset is very important. That is when the patient develops symptoms after administration of these drugs. So usually DIILD occurs usually within weeks to months. Not beyond that, but yes, sometimes it is definitely beyond that also. So that history is also important. Then one more thing I would like to say, that there are 3 certain situations where diagnosis of DIILD is very difficult. When methotrexate is given in a case of rheumatoid arthritis, which itself causes ILD. So that time DIILD diagnosis become difficult. And if 2 toxic drugs are given simultaneously, then also it becomes difficult. And sometimes, like Sir said, a case of phenytoin. Patient was on phenytoin for 5 years. Then no one can expect phenytoin-induced HP. But it was acute toxicity due to phenytoin. So sometimes this is a challenging situation.
Yeah, those are very interesting points which you have put forward. Because many a times now, as we hear through this lecture, it looks like drug-induced ILD is a very simple thing. You have a drug, it causes an ILD. But if you see the prescription of your patient, it will contain some 50 drugs. He will be visiting a pulmonologist, he will be visiting a cardiologist, he will be taking painkillers, more and above adulterated with Ayurvedas, homeopathies, and so on. So I think evaluating a drug-induced ILD actually requires a lot of patience and going into in-depth analysis of their prescription. And whenever we suspect, I think it's worthwhile you spend a lot of time going back through their prescriptions, because the current prescription may not contain the inciting drug. Maybe the prescription previously would have had the drug, and right now the patient might be showing to you a prescription which totally doesn't have the drug. And another thing, one another reason which Dr. Shubhra also touched upon is the eosinophilia. Sometimes it can appear as a part of a DRESS syndrome. You can have a drug-induced eruptions, eosinophilias. Along with that, also you can have an ILD-like pattern. So these are very, very interesting points, and I think a high index of suspicion, and maybe you become a police officer rather than a doctor whenever you are evaluating a patient of a drug-induced ILD. So with this, we move on to Dr. Sharad. So now we heard the Fleshner's criteria for diagnosing drug-induced interstitial lung disease. Is that sufficient, or do you feel there is still a role of a bronchoscopy or a biopsy to confirm an ILD? Because now we have a lot of these cryobiopsies, a lot of access to bronchoscopies, even at periphery centers with a single-use bronchoscopes and so on. So do you feel like the criteria should be more robust rather than just believing on the clinical criteria?
Dr. Vishu, I'll start from my background because I had seen the time of ILD in India when everything was labeled as ILD. It was considered as the death sentence for a patient, and we used to start with three drugs: steroid, azathioprine, and acetylcysteine in all the patients. So everything was actually being treated as IPF, and it all changed after the recommendation came that more than benefit, these three drugs are actually causing increased mortality in ILD patients management of. That was the time when every ILD was being considered as IPF only. Now, in last 10 years since the registry ILD registry in India, we have become wiser that the most common ILD which we see nowadays is actually chronic hypersensitive pneumonitis, and there are certain stimulants for it. So we know what are the organic dust diseases, what are inorganic dust diseases, and all kind of exposure is required. Now, when it comes to management, undoubtedly we have to rule out any kind of infecting disease, because you only label idiopathic, like you asked this question to Dr. Khushboo also, that is it NSIP or it is drug induced NSIP? How do you differentiate it? So when you talk about IIP or idiopathic NSIP, that actually is the diagnosis of exclusion. If you cannot correlate it with any of the exposure, may it be drug, may it be inhaled antigen, may it be occupational exposure, anything. So drugs, actually speaking, lungs are the most sensitive organs. Whether it is Bhopal gas plant, whether it is World Trade Center tragedy, lungs were affected, they are affected. Like Dr. Khushboo said that in silicosis, we see peripherally placed PMF lesions, and in sarcoidosis typically it is parahilar fibrosis which is more often seen. But if you come to WTC lung, it actually completely mimics sarcoidosis. There were nodules in the septa, and there is parahilar involvement, and then there is popcorn calcification. So diseases can actually have overlap. One thing, they will not follow rules. Rules are to be followed by the clinicians and the patient. Diseases don't follow rules. So you can't make a pencil sharp margin that this is NSIP and this is drug induced NSIP. Maybe we are not able to identify the antigen, but it is something which is causing this inflicting injury in the lungs.
Yeah. And Dr. Right? If I'm not cutting you short, sir, Dr.
No, fine. Please.
What is your take on this bronchoscopy in drug-induced ILD? Like we heard from Dr. Sharad saying that there can always be an overlap, therefore it is worthwhile to consider possibly a biopsy diagnosis. Would you concur with that, or would you want to, you have a different opinion on that?
Sometimes it is very difficult to differentiate. We cannot differentiate whether we are getting the opacities or shadows due to drug-induced injury, or maybe you have an immunocompromised host. He could have some other diseases. It could be infection or malignancy. So in that regard, definitely bronchoscopy will help. BAL will help. Possibly you will be able to differentiate certain infections, maybe pneumocystis, tuberculosis, which is very prominent in our country, nocardiosis, fungal, viral, parasitic infections. Beside this, there could be certain malignancies also could be underlying. So the biopsy could help. In those cases, particularly lymphangitis carcinomatosis or lymphoma, there are certain cases, if we take a biopsy of those, maybe the pattern, whatever we are taking, and the histopathology we get, that could be in other diseases as well. The BAL routine may give you a hint. Maybe it could be a drug-induced lung diseases. If you have more lymphocytic, maybe more than 25%, maybe it could be in that. If it is you are getting a BAL eosinophilic, maybe some proposition of acute or chronic eosinophilic pneumonia, and maybe the drug could be the offending agent. So in my opinion, whenever the differentiation is very difficult, and in our context, when the infections are so much predominant, the bronchoscopy will definitely help.
Yeah, very true, very true. Because even when we think about drug-induced ILD, we are going to think it as a diagnosis of exclusion. So when you move to a diagnosis of exclusion, I think you need to have
Whole
done
lot
at least a
of
BAL, if not a biopsy, before you start looking into terms of a drug-induced ILD. So with this, I'll again come back to Dr. Sharad. So we know that we heard from the talk as well, like methotrexate can cause a interstitial lung disease, but I think a year or back later we had an extensive review saying that methotrexate is not the culprit drug and it can be used safely. So what is your take on this methotrexate induced drug toxicity? If you find a rheumatoid arthritis patient on methotrexate worsening, would you still give it or would you like to stop as we evidence from the old literature?
So that's the conflict of interest. Whenever we discuss these cases with our rheumatologist colleagues, they will always deny that methotrexate doesn't causes pulmotoxicity. But in my 20 years practice of chest medicine, I have seen at least 6 documented patients myself of methotrexate induced lung injury. There are specific criteria which will be followed. The most confusing thing is that methotrexate induced lung injury actually also has presentation with fever. A patient who is on methotrexate and leflunomide or methotrexate and steroids develops interstitial shadows, comes to you with fever, anybody will think of a opportunistic infection or atypical pneumonia or viral pneumonia. So, as rightly discussed with Dr. Bansal also, that you perform bronchoscopy, you rule out active infections, you rule out opportunistic infections, you surrogate markers of infections and sepsis are to be considered. Once everything is done, you stop methotrexate and you see the response of that.
Yeah.
Because it's not a common thing, but being placed at a tertiary care center, we very often see unusual cases, rare cases.
Yeah.
So I have seen more than 6 methotrexate induced lung injuries. Simultaneously, when a patient is on leflunomide, it is also a notified pulmotoxic drug.
True. So I think it's the most
Right?
probably the add-on effect of leflunomide as well.
Yes, undoubtedly. Yes.
Yeah. So as we are speaking about methotrexate, which is again a anti-cancer drug, now we'll move on to Dr. A.K. Singh, sir. So we know that methotrexate has the potential to cause an ILD. So what other anti-cancer drugs in your routine clinical practice you see causing an ILD, and whether oncologists do actually refer you a case with a suspicion of an anti-cancer drug-induced ILD?
I think the answer is already given by Dr. Padma. I am just adding the 2 points. She has enumerated the number of oncologic drugs which are responsible for development of ILD. The 2 important practical problems is really challenge for the clinician, radiologist, and oncologist to make a diagnosis of onco-drug-induced interstitial lung disease, because the 2 type of presentation, most of the patients, they have interstitial pneumonia, like GGO presentation, and organizing pneumonia. And both type of presentation is also present in infective pathology. So it's a very, very difficult to differentiate whether the extension of malignancy or it is the secondary infection, patient develop pneumonia because it's already having the immunocompromised state. And third thing, it may be in a drug induced. So that should be the diagnosis of exclusion. But I think the bronchoscopies and rule out the infection possibility, a little bit role of the PET CT is there by which we can predict that this patient is particularly having the drug-induced ILD. Otherwise, diagnosis is very, very difficult for everyone.
True, very true. Yeah, even it becomes in fact, if you take a PET CT scan also, sometimes they may actually be PET-avid. And you take a biopsy, you end up getting an organizing pneumonia. Now you are in a confusion whether it is a true representation or it is like a part of the lung which you have taken, which is not actually a malignant, which is not your target lesion. So there are a lot of ifs and
points I want to add with if a patient is having associated lymph node or pleural effusion, it is unlikely to be a drug-induced complication. Probability is more that we are dealing with the more of infection or the malignancy.
Yeah, true. That's a very, 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 very interesting point. Yes, because many times you don't see a lymphadenopathy with a drug-induced ILD. So with this, we move on again to Dr. Padma, who started all this discussion about the drug-induced ILD. So now we have an entire gamut of biologics where humans have actually become the guinea pigs. So you don't have very robust data dating back to years. We just have a data for 5 years maybe for an FDA to approve the safety of the drug. and we start using it left, right, and center on almost every patient. And even pulmonologists are crazy about using these drugs off late. So, what do you really see? Especially when these biologics are used, there is always a possibility of an immune mediated toxicity to the lung, but it becomes very difficult to establish an immune mediated toxicity to the lung because the greatest mimickers are the ILD progression per se or an overlying infection. So in your experience, how do you say that this biologic is causing this ILD and not the infection or the disease progression per se?
Yeah, so usually we need to make use of tools, most important interventional role like a bronchoscopy and a bronchoalveolar lavage. There's no definite, diagnosis. A BAL usually helps to exclude an infection. So you do a BAL more to exclude infection or maybe a malignancy which may be lingering in the background. There have been biomarkers which have been there, but they are not yet validated. Now, what is the role of BAL is if you are having a drug and if you see most of the drugs, they can cause a lymphocytic alveolitis. So if you see a more than 25% lymphocytes, and especially a CD8, CD4 reversal, then it's more likely to be a drug-induced ILD. Other few things that you see sometimes with methotrexate, you may see some foamy macrophages. And sometimes you may have a eosinophilic picture, especially with DRESS or in a eosinophilic pneumonia, you may have a eosinophilic predominance. Now, if you have a DH-like presentation, you may see hemocyte-related macrophages in your BAL. So BAL definitely has got a great role in especially drug-induced lung disease, not a definite thing, but it helps you to exclude infections. Now, your cryobiopsy is very important nowadays because you may see some of the drugs causing a granulomatous pattern, especially the immune checkpoint inhibitors. So, or a HP-like pattern. So, a combination of BAL and maybe a cryobiopsy and even a mediastinal lymph node biopsy to pick up a granulomatous pattern to sort of pick up a drug-induced lung disease is definitely helpful. So, it's helpful to rule out an infection first before we go ahead with further treatment as a drug-induced lung disease.
Yeah, so this Dr. Padma has brought about a very beautiful point. So I think more than a clinical criteria per se, like these are the decisions which is going to change the outcome of the patient in a big way. Then I think in that cases, it is always worthwhile to consider either a BAL or if you have an access to a cryobiopsy or something, it's better to do it because your decision is going to change the outcome of the management in your patient. So now we'll move to Dr. Shubhra Jain. So you know that you have diagnosed a patient with a drug-induced ILD and he has already got an established ILD. So are you going to just stop the medication and wait and see if this ILD resolves as we saw from phenytoin-induced hypersensitivity pneumonitis? Or is there a role of steroids given the fact that it is again an immune-mediated response to the drug? So what does the literature say and what is your personal experience on that?
Basically, the management depends on severity of disease. If it is mild and not impairing patient daily activities and patient is least symptomatic, then we can just withdraw the drug and no need of even steroid. But if it is severe, like patient is requiring oxygen or if it is life-threatening, then definitely there is role of steroid, especially if it is eosinophilic pneumonia or if it is OP and obviously HP. And if these patterns are in DI-ILD, then steroids do wonder. However, if the lesions are very much progressive and there is fibrosis, then there is no role of steroid.
Yeah,
so just
excellent point.
In mild cases.
Yeah, it's an excellent point because it depends entirely narrows down to the severity. Let's say the patient is totally asymptomatic, and I think then it is worthwhile to wait for the response by stopping the drug rather than being very aggressive on putting these patients on steroids. But if the patient is admitted in an ICU or requiring oxygen, then it makes all the effort worthwhile in initiating at least a steroid trial and looking for response. So with this, we move on to Dr. Ankit, who is very interested in bronchoscopies and allied procedures. So you touched upon the bronchoscopies and biopsies, and you said that, yes, I will do a bronchoscopy and a biopsy before I label a drug-induced ILD. So what sort of pattern of presentations you see in this biopsy when you really do it for a patient with a drug-induced ILD?
Most common involvement of these patterns is mostly in the parenchyma. In parenchyma of the lungs, you can get the interstitial or the involvement of the alveolar or the vascular component. The most commonly components that is involved is interstitial one. So what it has been seen that a single drug may have multiple patterns of involvement. So it is not necessary that one drug will have only one pattern. So the various patterns we commonly encounter and yes, it is very difficult to differentiate them from the actual disease also. They are like cellular or fibrotic NSIP. You can get in your histopathology. You can get the pattern of the usual interstitial pneumonia in which you have multiple fibroblasts. You can found some non-caseating granulomas like hypersensitivity pneumonitis. You can get the pattern histopathological patterns of organizing pneumonia with or without bronchiolitis obliterans. We know that eosinophilic pneumonias are very common in drug-induced, so there is multiple infiltrations of eosinophils in these particular segments. There could be diffuse alveolar damage, and you can got inflammatory vessels in this particular component. So the important take is that a single drug can have a multiple type of patterns. There is no specific pattern for a single particular drug.
Yeah, very true. So I think your pathologist will have a fun time interpreting a drug-induced ILD, because I think in your drug-induced ILD, you can see all patterns of presentation, as Dr. Ankit has already said. So now we again move on to Dr. Sharad. So in your clinical practice, once you diagnose a patient with a drug-induced ILD and you stop this patient of the offending drug, have you seen that even after stopping, there was a progression of this ILD in certain cases, or it is always a static phenomenon, or does it behave like some sort of a chronic radiation pneumonitis, where even after stopping the radiation, after a few years, still the patient can develop some sort of a residual lung damage?
So, in non-neoplastic diseases, whenever we see drug-induced ILD, stopping the drug and introducing steroid as per the severity, most often we have seen resolution of the disease. It's not progressive, rather it is one of the most responsive ILD which we see in our practice. But when it comes to neoplastic patient developing ILD to anti-cancer drugs or complicated by radiation, then definitely even after stopping the drug, either the disease is static, and in couple of patients I remember that the ILD was extensively progressive, and unfortunately that led to the fatality in the patient. But if I have to measure what is the problem, how big is the problem, if I have seen 100 patients of drug-induced ILD, at least 80% will respond by stopping the drug and introducing the steroids. Of neoplastic patients, 2 patients I have lost because of progressive ILD. Despite of stopping the drug, they had progressive ILD, because these patients were not only on chemotherapy, they also had radiation.
Yeah. Excellent points. This is something which we have to note, especially as Dr. Sharad has said, in cancer patients, because these patients don't not only receive biologics or medications, they also receive radiation. So it becomes really difficult for you to say whether what you're dealing is a case of a drug-induced pneumonitis or a chronic radiation pneumonitis. So if you have a chronic radiation pneumonitis, still you are justified in putting these patients on mild dose of steroids. So that has a therapeutic implication. So this is a very, very interesting point. And as Dr. Sharad has said, even in our experience, most of these drug-induced ILDs, they tend to not progress once the offending drug is de-escalated, just like what happens in hypersensitivity pneumonitis. You know the offending antigen exposure, you stop the antigen exposure, the outcomes are going to be much better. But I'll move on to Dr. A.K. Singh, sir. So you have a drug-induced ILD patient who has been taking the drug for quite some period of time and already developed architectural distortions and severe forms of ILD. Would you be inclined to start an antifibrotics like an nintedanib or a pirfenidone in this patient? Or how do you really judge initiating these antifibrotics in these patients?
So it is basically a difficult answer because we don't have any guidelines. Once on the CT scan, we have the significant fibrosis and the patient is symptomatic because of that problem, and there is a gradual increase in the lesion, then I will prefer to start antifibrotic drugs, because there is no control trial for that. Because fibrosis is a reversible component, I will try to start antifibrotic drug in that condition patients, not in all patients. If there is only fibrotic band, patient is not symptomatic, is having a ground glass opacity, I will not prefer to start antifibrotic drug in this patient.
Yeah, perfect points. Because right now, what at least initially maybe medico-legally it was difficult, but right now at least we have a term called as a progressive pulmonary fibrosis. So I think if you go by that criteria, after 6 months you get your CT scan done or you get your 6-minute walk test done and a PFT done, and you see there is a significant decline in your FVC, then even a drug-induced ILD can behave like a PPF. And only once you demonstrate this progressive fibrosis, then I think probably we are justified in starting these antifibrotics for these patients. So now I'll move to Dr. Padma. We have discussed a lot about these pharmacological therapies, steroids, antifibrotics, stopping the drug and everything. But do you think that we are underutilizing the non-pharmacological therapies in the management of occupational and drug-induced ILD? So what is your take on this, and how do you really suggest your patient to stick on to certain non-pharmacological management of these ILDs?
So even before starting the pharmacological therapy, the first thing is removal of the patient from the offending agent, whether it be an environmental cause or a drug. That becomes the first part of the therapy, non-pharmacological. Second thing, obviously, pulmonary rehabilitation, stopping of smoking. Then a lot of these people need a lot of nutritional counseling. There may be a lot of patients with silicosis, malnourished. And when you have a progressive massive fibrosis and the patient is going to be given a verdict that it's an irreversible disease, then obviously psychological counseling also becomes very important. Then the other therapies can be tried out in the form of oxygen therapy if they develop respiratory failure, or the fact of that we could also consider them as part of lung transplantation if you call it as a non-pharmacological therapy other than drugs. And support and emotional support and nutritional support and vaccinations definitely play a role. So we need to look at pulmonary rehabilitation as a whole and stopping smoking.
Yeah, excellent point. So yeah, that's what actually most of us tend to forget or don't see a dramatic response in a short period of time with non-pharmacological therapy, but that is the one thing which actually changes the quality of life of the patient. So I think we need to adhere to these non-pharmacological managements, and at least we need to discuss with them what are the realistic life goals which they have, especially when you're dealing with some sort of an advanced forms of interstitial lung disease. So with this, I'll move to Dr. Shubhra. So what is your opinion on vaccination in these patients with occupational and drug-induced ILD? I know that we have a lot of guidelines on these. So what would you suggest to your patients? Which all vaccines would you want to choose, given now you have an entire gamut of adult vaccination program?
So just if we talk in short, that we know that infections are exacerbators of ILD, and they are also causing progression of ILD. So usually I advise pneumococcal vaccine as well as influenza vaccine yearly, and if patient is elderly, also herpes vaccine.
Yeah. So any cutoff you want to choose for a herpes vaccine? So if you go by these gold guidelines, that is for COPD per se, but we really don't see actually a direct evidence for herpes vaccination providing a clinically meaningful benefit in a COPD, but the gold guidelines have recommended it. So what sort of patients? What sort of patients do you choose? Is there any immunocompromised patients with a diabetes, elderly, or it is like a random any patient with an ILD, you go ahead with a herpes?
No. So if the patient is immunosuppressed, and especially if patient is elderly, like more than 65, and if on immunosuppressive medication, then we can advise. But the most two important vaccine are pneumococcal and influenza.
Yeah. And again, one more question to you, Dr. Shubhra, since you have an extensive experience with the silicosis and tuberculosis. So do you see any role of a quantiferon TB gold and an INH prophylaxis in your silicosis ILD patients? So right now the government has come with a TB preventive program. But when it comes to silicosis, are you 100% sure that you have ruled out tuberculosis before you initiating this patient on a TPT?
Look, like Indian guidelines though do not suggest TPT for silicosis, but WHO has selected few patients in which one is silicosis, and if you have ruled out completely tuberculosis by either BAL doing bronchoscopy or BAL or anything else, or sign and symptoms are not suggestive of TB, then you should do either MT test or IGRA. And if that comes out to be IGRA is positive and you have ruled out tuberculosis, then you can give TPT prophylaxis if we talk about developed countries. But it is not in India.
Yeah. So, but my doubt is, let's say that you have a patient of silicosis. You have found out that he doesn't have active tuberculosis at present. You do a quantiferon on TB, it comes positive. You initiate this patient on 6 months of INH therapy. What is the justification that this patient is never going to have another episode of tuberculosis in his lifetime? And wouldn't it breed a sort of a INH monodrug resistance in a later stage? Or what is your experience? Is it is it only a hypothetical possibility, or is it something in reality do you see on your day-to-day practice?
So if we talk in reality, this also applies for household contacts. Like government is giving INH prophylaxis to all household contacts of tuberculosis patient. Even so, these patients can also develop in future tuberculosis. So that holds both for silicosis and HHC. So if we talk practically, India is an endemic country for tuberculosis. So I will not prefer TPT for silicosis patients because usually, actually, these patients had already taken 1 or 2 courses of ATT when they usually come to us. And TB is rampant in silicosis because of macrophage dysfunction. So it is usually they have taken courses. So I won't give TPT to these patients because of problem of INH resistance as well.
So this is a very, very controversial thing. That is why I thought I will ask you, because we are giving, but there is no justification that this patient will never pick up another set of a tuberculosis, and that wouldn't be a INH drug resistant tuberculosis. So this also brings us to a very important thing that we should possibly, when these patients develop tuberculosis later in the life, it is always worthwhile to send for a line probe assay as well as to rule out these monodrug resistance, because many of these patients would have developed some sort of, would have received a TPT or would have had a prior history of tuberculosis. So they are more prone to develop these severe forms of drug resistant tuberculosis. So now we move on to Dr. Ankit. So right now, even at our center, we had very good successful outcome of a silicosis patient who has got a destroyed lung, undergoing a lung transplantations and doing fairly well. This is almost like 6 months or 8 months after the transplant. So would you really refer a patient with an occupational lung disease like a silicosis for a transplant? And what post-transplant complications you expect which would be different from any other patient?
Basically, when we are clinically assessing our patient, then it is important that we see what is the lung reserve. And if the lung reserve is very poor, both clinically and maybe through spirometry also, and there is persistent clinical deterioration, and it is hampering the quality of life of that patient, and patient may have severe pH in those conditions. Maybe these are few factors in which possibly we will look into the context if the patient could be referred for a lung transplant. Yes, there are reports in India also and outside India that in certain end stages occupational diseases, whether it could be silicosis, asbestosis, variolosis, pneumoconiosis, or coal worker pneumoconiosis, there has been option of lung transplant being given to them and done to them, and with a reasonable survival. There are certain things that I will look into context before referring also. That is, I have to rule out the active infection, that is like tuberculosis in those set of patients, particularly with silicosis, as it is very in good numbers in our country. So that should be ruled out. Particularly in some set of patient, there is a chance of malignancies. So these malignancies may be, there is a high risk of death in those patients and possibly not suitable for lung transplant in that way. The most important factor before transplant, I would be looking about your functional status. If they have a very limited functional status, they are possibly the poor potential for post-transplant for rehabilitation. So that is an important context, because over the period of time, as other patients with lung fibrosis and COPD, there is a lot of loss in muscle mass and the various things related to it. So that has to be taken into context, whether the patient post-transplant would be able to achieve a good rehabilitation.
Yeah, these are perfect points. Like, because many of the times when we choose these patients for lung transplantation, especially silicosis patient, they are totally emaciated. And if you are in a hurry without putting them for a good pre-transplant rehabilitation, then generally the outcomes are going to be much poorer. So I think building up of a proper nutrition and building up of the immunity prior to subjecting these patients for a transplant is very important. Another thing, as we have always discussed here, is the infections and the tuberculosis in India, which is very, very common. And I think you need to be very strict with your evaluations to rule out an active tuberculosis before you actually put these patients for transplantations. So now I'll move to Dr. Sharad. This is something which we never actually realize as a pulmonary physician, and many a times we tend to ignore just looking into the lung. But actually, the occupational lung disease extends beyond the lung in many cases. We have seen a lot of these connective tissue disorders occurring in patients who has got a significant occupational exposure to silica and other occupational dust. So, in your experience, which are the sort of these occupational lung disease where you will see predominant and extrapulmonary manifestations, and what we actually need to look into these patients when we evaluate them for the same?
So, specifically talking about silicosis and pneumoconiosis, the most common extrapulmonary thing which we have already discussed, and as Dr. Ankit Bansal has mentioned, that it is the pulmonary cachexia which we have seen it very often. One thing. Secondly, because of repeated doses of steroids or because of repeated doses of immunosuppressants, definitely secondary infections has led to recurrent admissions of these patients. But if you talk about like a CTD ILD patient who present with joint pains or rashes or some skin manifestation, that is typically not a presentation in occupational exposure, right?
But wouldn't silica cause per se high risk of scleroderma? Like, isn't it?
Undoubtedly, like I had shown in my presentation, exposure to silica can lead to scleroderma. Then definitely it can cause rheumatoid arthritis.
Yeah.
It is also one of the factor for development of PMDM disease or polymyositis or dermatomyositis. It is one of the factor for development of sarcoidosis, which we have seen very commonly with carbon nanoparticles during the World Trade Center tragedy. So these kind of manifestation we have seen practically in our day-to-day practice by after exposure to occupational dust.
Yeah, Dr. Shubhra, Jain, you wanted to add something?
Actually, we have published 3 cases of Erasmus syndrome, that is silicosis with systemic sclerosis. So we see systemic sclerosis as well as rheumatoid arthritis in silicotic patients. Rest, I have not seen SLE, but sir has described it is mentioned in books.
Yeah, very true. So I think there is you need to look even a little beyond the lungs also, because many times we think that these patients are rheumatoid arthritis. As Dr. Padma said, if you don't go into their chronological history, possibly they could have been from an area where they had a significant exposure to this silica dust as well. So I think even in sort of an established connective tissue disorder, I think it's worthwhile to see if it is primarily a CTD or a occupational induced CTD. I think, if I'm not wrong, that syndrome is also called Erasmus syndrome. It's been quite before long I have read that, so I'm not pretty sure about it.
Yes,
so yeah. So Dr. Padma, like one another important thing which we always neglect is we always keep speaking about tuberculosis in India, but unfortunately most of these cavities also turn out to be, in certain cases, fungal infections and malignancies. So somehow we are biased towards tuberculosis. Yes, tuberculosis is the most common thing which we see, but not all cavities in silicotic patients should be a tuberculosis. So what is your experience on seeing cases of chronic cavitary pulmonary aspergillosis or squamous cell carcinomas in these patients? So what would be the characteristic clinical features which you feel would tend to help you to diagnose these cases?
Yeah, so just like the saying goes, not all wheezes is asthma. So I should say that not all cavities are tuberculosis. Since the burden of TB is very high in the country, we tend to mistake, mostly at the general practice that all cavities get treated as tuberculosis, but they actually turn out to be maybe cases of silicosis or even cavitary sarcoidosis for that matter. Now, as we know that all these cavities are a home for a lot of these aspergillus infections, we could see aspergilloma, or even they could be a precursor for malignant transformation, and we could have malignancies setting up in these cavities. So if a patient comes with hemoptysis, loss of weight, in addition to thinking about tuberculosis, we should also think about, is there an aspergilloma sitting in the cavity? A CT scan would probably be helpful if we have an aspergilloma there. Or we also need to know about a malignancy, especially if a patient is also a smoker. So we need to have a differential diagnosis of all these patients and just not only think about tuberculosis. We need to think about aspergilloma as well as a malignancy coming up in a pre-existing cavity.
Yeah. So I think here comes the most important role of the serial radiographies in these silicotic patients, because at a first instance, you just see, you don't know whether it is the same cavity which existed or is it a new cavity. So many a times what really happens is either the doctor doesn't ask for the serial scans, like serial x-rays, at least even you don't need a scan. If you see the serial x-rays, and if there is a progression of the lesion, then that may be the earliest sign before it actually forms a cavity, and for you to interpret it as either a tuberculosis or a malignancy or a chronic cavitary pulmonary aspergillosis. So I would like to come to Dr. Sharad. I know that we are taking a lot of questions, but I think these are very practice pertaining points to most of the audience here. So when you see, when you speak about chronic cavitary pulmonary aspergillosis, so how do you really diagnose? Like, I think Denning has beautifully given a lot of classifications about this chronic cavitary necrotizing pulmonary aspergillosis, chronic cavitary pulmonary aspergillosis, chronic semi-invasive aspergillosis. So, how do you really start working up these patients when you suspect a high degree of suspicion of a fungal superadded infection?
So obviously, first and foremost is the radiology. If you see, because the radio, especially the CT scan, if you see there is crescent sign, or there is a pericavitary nodular infiltration, or there is a halo sign, then definitely you know that by the correlation of symptomatology that it's an active ongoing fungal infection. You rule out with the sputum examination or the BAL, then definitely you carry out the blood investigation for level of serum Ig as well as serology of for aspergillus and galactomannan levels. And if the patient has massive hemoptysis, recurrent hemoptysis, or respiratory failure with recurrent fever, obviously you have to start treatment for a active fungal infection. Silicosis patient, they have already damaged underlying parenchyma, pre-existing cavity, which is actually the growing field for a fungal infection. And once you pinpoint that this is active ongoing infection, you have to start with the treatment, which will include antifungals as well as steroids.
Yeah, so when we speak about chronic cavitary pulmonary aspergillosis, as we said, so generally we take a dictum of like 3 months progression. You see the 3 months, there is a worsening. Along with, you can even get a serum specific IgG against aspergillus. So if you don't want to do an invasive test, you just get a specific IgG against aspergillus, and then you take into the clinical criteria where there is a fever, loss of weight, loss of appetite, and you look into the serological criteria, and you look into the radiological criteria. If there is progression, then probably yes, you're dealing with a case of a chronic cavitary pulmonary aspergillosis. The importance of identifying this is because you have a correctable etiology. Let's say you are treating these patients with a voriconazole or an itraconazole for that matter, then probably you can prevent the progression of these fungal things. So one another interesting experience we had, I think it's little out of context for this, but I think it is of relevance. So whenever you see a cavity where you are strongly suspecting a malignancy and you take a biopsy, and if the biopsy shows only fungal, don't believe always that it is a fungal infection. Because what really happens is it's just a fungal colonization of your underlying malignant process. Because once malignancy happens, necrosis sets in, which acts like a breeding ground for your fungus. You take a biopsy, you get a fungal infection. But if your pretest probability for malignancy is quite high, then probably you have not taken a deeper biopsy. This we have experienced in 2 or 3 cases where when we did a total bronchoscopic debulking of the tumor, the superficial layer was all fungus. But as you go deeper, you see a lot of these malignant process actually happening. So I think this field of occupational lung disease is a very, very interesting one, because whatever you see in the textbook of all the radiological presentations, you can see everything in an occupational lung disease, starting from your lung cavities, airways, pleura, into the nodes and everything. So one more thing which I wanted to ask Dr. Shubhra, because she would have seen most of these cases. What is your experience of broncoliths happening inside the silicotic patients? Because we have seen the silica nodes being very hard, which erodes the bronchus, comes inside the airway, and presents to you like a tumor-like lesion with a hemoptysis. Have you seen in your setting? Because we see occasionally, we don't see it very
I
often.
have seen reports, but personally, I have not seen bronchiolids eroding into bronchus. But I have seen one in AIMS Jodhpur. They have done the bronchiolids is completely going inside the bronchus. But I have personally not seen.
Yeah. Okay. So I think we have touched upon most of the aspects of occupational and drug-induced ILD. So I'd like to ask from each one of the panelists here one concluding points. I would ask Dr. Shubhra and Dr. Padma to say about occupational, and Dr. Sharad and Dr. Ankit to say about drug-induced. So we'll start. Which one point you feel that the audience should take away from all this talk we had about occupational lung disease from Dr. Shubhra?
I will say prevention is cornerstone of treatment, and early diagnosis helps to prevent morbidity as well as mortality.
Yeah, and Dr. Padma, anything on occupational ILD which you want our participants to take home as the key message from your experience?
Most important is a very important occupational history in all patients of interstitial lung disease. So occupational history becomes very important because it is important to know the prevention part of it so that the disease doesn't get further aggravated. And obviously even for compensation purposes. So occupational history in detail, including the chronology I kept telling, becomes important.
Yeah. And Dr. Ankit, from drug-induced ILD point of view, one thing which you want our audience to remember?
Suspicion is very important. So better chronology of the clinical disease, any change in radiological pattern, you need to take a detailed history of drugs the patient is taken. Maybe something is causing that unusual pattern.
Yeah. And Dr. Sharad, anything with respect to the diagnosis and management? One point for the audience here?
Most importantly, high degree of suspicion is first and foremost. So if you see that your radiological pattern and symptomatology of a particular patient is not fitting in a pre-existing any of the lung disease, do evaluate what is prescription he is following, what is the new drug introduced to his prescription, and whether it can be one of the inflicting injury leading to lung damage. One thing, if you suspect any of the drug, please do search it on pneumotox.com. And I will like to address one thing also. Drugs not only cause ILD, they can actually cause pulmonary edema, they can cause pleural effusion, and they can cause mediastinal lymphadenopathy. If you clinically search this on pneumotox, you will get n number of drugs which are labeled to cause lymphadenopathy. In fact, phenytoin can cause lymphadenopathy. So it's not only interstitial pneumonitis which happens because of drugs. True. I had one very bad argument with the oncologist that patient developed pleural effusion and they were suspecting tuberculosis. Actually, it was pleural effusion secondary to dasatinib.
True. Very true.
So, high degree of suspicion, cross-check all the drug-related information on pneumotox.com. It's a boon. It's a very good site which tells you each and every side effect which a drug can cause in lungs.
So I think we have had interesting points. So from my side, as Dr. Sharad said, if you have a doubt, go to pneumotox. That is the simplest thing which you can do. Number two, always consider occupation and drug as a cause of ILD. Many a times you don't look into it. You are evaluating ANA, you are evaluating anti-CCP. Even we go to the point of myositis, but we never go back to the history to look for occupation and drug. Always see your prescriptions of your patients and ask if they are taking any drug beyond your prescription. In India, you have alternate systems of medicine for which we don't know what is the exact pathological effects it's going to have on your lungs. So always look into the alternative prescriptions. Always go back to the previous prescriptions. And before you label anything as an idiopathic NSIP, that was the first question we had, and that's a very valid point. It is going to be idiopathic just because we don't know. It is not a diagnosis per se by itself. We don't know, and we don't know can be because of an occupation or because of a drug. So I think I thank all my panelists for an excellent contribution. But I think we have got some few questions from the audience as well. So I'll just start off with again our panelist, Dr. Ankit. Can ACE and ARB cause an ILD? Have you noticed?
They have been known to cause mainly the cuff syndrome, but not really the interstitial lung disease. Yes, but there's a different type of mechanism there. Maybe the bradykinin contribution could be there. So not really.
True. So even I think none of us have really seen it, but maybe if you go to pneumotox, you may still find an evidence possibly that may be causing an ILD.
Yes.
So, and
there is one case report of something called a MESA syndrome where subclinical ILD has been reported in smokers with ARB. Just came across the report.
Can you repeat the syndrome, ma'am?
Yeah, it is MESA, I think. So MESA syndrome or MESA article that they had reported of subclinical ILD in smokers.
So that's what so now as you Google, you are going to get more and more. So go to the pneumotox if you have a doubt, because any drug has a potential to cause a ILD. And to Dr. Padma, which type of occupational ILD would you like to go for a biopsy? That's from Dr. Dheeraj Jaiswal from Madhya Pradesh.
Most of the times we can avoid a biopsy if the history has been adequately taken, like silica exposure, and you have a classical HRCT pattern. But in case if you have an UIP pattern, which is a probable UIP, and there could be a possible occupational exposure, especially if you're suspecting that it could be a compensation, and if you find asbestos fibers in a lung biopsy, the whole diagnosis changes from an idiopathic UIP to an asbestos-induced UIP. So definitely that would be a candidate where we would suggest a lung biopsy. And so I would think about that as a indication for lung biopsy.
True.
Especially for compensation, you have to prove it. Or even for a case of silicosis, if the occupational history is not very classical, but there is a doubt, then definitely if a composition is ensured for a patient.
Yeah. And we have a question for Dr. Ankit, Dr. Kiran from Trivandrum. Are there definite criteria for classifying severity of an occupational ILD and grading disability for granting compensation? I think ILO or something is there. So I think Dr. Ankit would be the best person to say on this.
I think they have made certain criteria on that. Again, the clinical assessment and the lung functions are an important parameters to assess the severity of that sort of patients. And regarding the compensation, not only the clinical criteria or the assessment, the many things are seen, that what is the productive age group of the patient and how could he contribute in the working in the family. So all these points has been taken into consideration before granting the compensation also.
Yeah. And we have a question to Dr. Shubhra from Dr. Trinab Chatterjee. Comment on business or sugarcane industry as in Maharashtra causing an ILD. So anybody from here has an experience on business or sugarcane?
I don't have.
So, Dr. Sharad, would you want to take it? Maybe in Delhi, there must be some sort of.
We have. I practice in Ghaziabad, and we have seen a couple of cases of businesses, because UP is another state where a lot of sugarcane industry is there and a lot of sugar industry is there. So this is definitely exposure related and typical occupational lung disease. A patient will come up with similar same symptoms of long-standing cough and progressive breathlessness, and the exposure history is one of the things which will establish the diagnosis. There is interstitial pneumonitis. So the thing is that after evaluation of their impairment, functional impairment, if there is gross desaturation on 6-minute walk test, the walk distance is reduced to 50%, definitely the advice is to switch the job. We have to completely change the occupational exposure. Yeah. So we have seen a couple of patients because of this sugar industry in UP.
Yeah, and we have a question from Dr. Bhavyaja from Maharashtra. I think to Dr. Shubhra, does steroids have a role in silicosis?
No, actually they don't have role. If it is acute silicosis, we know it is the whole lung lavage that is the treatment for silicoproteinosis. And steroid have only role when it is coexisting obstructive airway disease. Like patient is having COPD with silicosis, then definitely the treatment is like inhaled corticosteroid. Otherwise, there is no role of corticosteroid.
Yeah, I think this is a very, very important thing. In fact, steroids can even worsen your patient and can make them more prone to develop tuberculosis in your patient.
Yes.
So I think we have a question to Dr. Padma from Dr. Rida from Maharashtra. So any characteristic features of asbestosis? I think that is something which we need to discuss.
Yeah, so as I said, for asbestosis or lung biopsy, and you see the classical asbestos fibers, the spiral asbestos. Now that we know the importance, but as one of the panelists said about shipbreaking industry still going on in Gujarat, so we may still have workers who have been exposed to this, and the incidence of UIP developing in them. So a lung biopsy and finding the asbestos fibers in the lung biopsy sample, especially a cryobiopsy also, would be helpful in diagnosing.
True.
And including a BAL, finding the asbestos fibers.
And I think even radiologically, when you have a lot of these pleural calcifications, especially involving the mediastinal pleura, I think you should be little wary. Probably they could have had an exposure of asbestosis. And again to Dr. Shubhra, I think there is a comment about NTP. I think we touched upon it enough. So I'll go to Dr. Sharad again from Dr. Trinab Chatterjee. How many days of cardron or nitrofurantoin consumption usually causes ILD? Is it an acute or a subacute? And maybe hypersensitive pneumonitis or it after a prognosis? I think basically sir wanted to ask about what is the duration? Is it a dose-dependent toxicity, or what do you suspect in a case with a amiodarone-induced toxicity?
So amiodarone, when it talks, it is actually dose-dependent toxicity, and it is the deposition of the drug which causes hyper intense signal in the radiology. It is dose dependent and is not an acute hypersensitive pneumonitis type of picture which will come with first or second dose of it, right?
Yeah, so I think amiodarone is more of a chronic. You just generally happens after 6 months to 12 months of use, because I think the cumulative dose you require is in grams, like for you to develop amiodarone toxicity.
In fact, not only pulmonary fibrosis, it can cause cirrhosis of liver also.
Liver, yes, very true.
Cumulative doses.
Very true. And another question we have. Okay, I think again from Dr. I think we touched upon it. What are the DDs of drug-induced ILD? I think any ILD is a DD for a drug-induced ILD. So I think there's one other interesting question. Maybe I can answer. In paraquat poisoning, oxygen-induced fibrosis is very common. Very true. So whenever you see a paraquat poisoning, our target saturation is hardly like 85%. You don't keep more than that because oxygen per se can cause lung fibrosis. And Dr. Ankit, how airways get affected in drug-induced ILD? Any experience with airway involvement in drug-induced ILD?
Not really, more of a parenchymal, but definitely they can also be impacted. A certain inflammatory process may be going on.
Yeah, so I don't think bronchiolitis may be one such thing where there's an element of a small airway involvement in causing, because again lymphocytic infiltrations of the surrounding the bronchial distribution.
So surely bronchiolitis is one thing. Secondly, when there is drug-induced hypersensitive pneumonitis, it will always cause obstructive airway disease.
Yeah, true. It's a more of an airway-centric. And we have a question from Dr. Shreyami Saha from West Bengal. What is the prognosis of post-transplant in case of silicosis? I think we have 2 cases. Both of them till now are doing good. But as we said earlier, you need to rule out active infections, especially tuberculosis, build up their nutrition and put them on an intense pre- and a post-transplant rehabilitation. So again, I'll go to Dr. Ankit. We have Bhavyaja from Maharashtra, who is, I think, the best audience of the day. So many questions. So what will be the BAL finding in drug-induced ILD?
As previously discussed also in the panel discussion, maybe you could find more of a lymphocytic presentation if more than 25% of the total counts. Maybe it could be contributing to that. Similarly, there are certain patients who have acute and chronic eosinophilic pneumonia. If more than 25% of eosinophils, again, that could contribute to drug-induced lung injury.
Yeah. And we have another question from Dr. Sanket from Maharashtra. Prognosis in case of occupational ILD and drug-induced ILD, we have discussed. It depends entirely upon the severity of presentation. If you're going to have a severe presentation, probably prognosis can be little lower, but as we discussed earlier, drug-induced ILD tend to have a better prognosis because you stop the offending drug, they do much better. I think we have a competition for the best audience. Again, Dr. Shreyami Saha from West Bengal. How to differentiate between cold workers pneumoconiosis and silicosis. To Dr. Shubhra Jain, how do you like to differentiate cold workers pneumoconiosis from silicosis?
I think history will be more suggestive in cold worker, and Dr. Khushboo also pointed out some CT features which can differentiate between silicosis and cold workers.
Yeah, generally cold workers tend to have more of these emphysematous patterns and less of lymph node calcifications, unlike the silicosis, which presents either with more of eggshell calcifications, the typical eggshell ones, as well as they present with progressive massive fibrosis. Whereas cold workers is more of emphysematous sort of presentation because it mimics like a smoker, like it's
and
all
Kaplan
like
syndrome is also seen in cold worker with rheumatoid arthritis.
True, cavitating nodules. Yeah, very true. And we have from Dr. Shaibas, someone from Maharashtra. Does a normal chest X-ray exclude the diagnosis of extrinsic allergic alveolitis? Absolutely not. Because if you get an expiratory scan, you can still pick up some sort of an air trapping when you deal with expiratory extrinsic allergic alveolitis. So what is the role of BAL? We have already touched upon what are the different types of findings seen in drug-induced ILD. I think we had an extensive discussion. And again, Shaibas has asked, does HRCT of asbestosis resemble COP, cryptogenic fibrosing alveolitis? The answer is no. It can have a COP presentation, but along with that, it also generally it presents as an IPF-like presentation along with a pleural calcification. Again, Dr. Shaibas from Maharashtra, occupational ILD with a focal lung volume loss. When you have a focal lung volume loss, always think there could be an endoluminal obstruction, maybe a broncholith, which is causing a chronic post-obstructive pneumonia and a fibrosis, or a tumor, which is causing in an occupational lung disease patient, which is causing a focal volume loss. Again, we have from Dr. Shushma from Uttar Pradesh. I think we have done with most of the questions, and I think it was a very exhaustive and very informative for at a personal level as well. And I hope that every audience here would have had some sort of practice changing points which they will carry away from this webmate. And I think we have run short of time, and I think we have gone beyond the time limit. And like just like in ICC, where you have some penalty for overcrossing the over limit, I think we have overcrossed the time limit. So anyways, I would like to thank CIPLA and ICS for having given this opportunity for an excellent academic discussion. And I genuinely thank all the panelists here, and especially Dr. Amita Nenne for putting up such a hard work in making sure that the program runs well. And I think we'll conclude the session at this point of time, and eager to have you sometime later for a much more academic discussion. Thank you and good night.
Thank you.
Thank you.
Thank you, Dr. Vishesh.
Thank you.